Okay, so this is going to be a lecture about labor and delivery principles and labor management, really. Before we spoke about fetal heart rate tracings. And once we have a good understanding of how those are interpreted, that's an ongoing effort during your laboring patient. And that very much dictates your management if you can proceed with certain methods or where other methods may be preferred. So, but we have time as well. So we're going to go into some examples and putting it all together. So when talking with, your obstetrical evaluation, unlike other fields, especially like internal medicine, where you have this long sort of developed assessment, the obstetric evaluation is quick and focused. And it's supposed to only have a couple of key components. When you're on the floors and things like that, you see that the sign outs are very quick. And if they're kind of getting a little bit long, you see, especially attendings will get a little antsy and usually a little irritated because it shouldn't be that long. The important things are what's going to dictate your further management. So the maternal age is important. Your sort of one-liner you want to get used to. So maternal age, your G's and P's, which is your gravidity and parity, meaning how many times mom has been pregnant, and then the outcome. So do we remember? So they'll say a G, say 4, which means what? So you've been pregnant 4 times, and then you have, so you're going to say G4P, and then there's 4 spaces. What's this one? Live births. Yep. So say this will be a 2 for say. How about this one? This second column? Preterm births. Okay. So for her, she has had done this one, the third. That's the abortus. Yeah, that counts ectopic pregnancies, voluntary terminations, spontaneous miscarriages. So say 1, and the last column, living. Yeah, because sometimes you'll see if that doesn't add up. Sometimes if the child had like a neonatal demise, or even if they died later, that takes off there. So, and then obviously a pregnant patient, the parity number will be 1 less than the gravidity, unless you're dealing with twins, because then you'll have your live birth is 1, so she'll be para 1002, for example, right? Because she's had 1 live birth, but there were two babies. So just watch out for that. Weeks gestational age, which is probably the most important part of your one-liner. And then chief complaint, which is, say, she's here for leakage of fluid or vaginal bleeding or contractions, or sometimes there isn't one. She's just here for routine screening, like we reviewed our non-stress testing, stuff like that, because that focuses on what you're looking for. Then you want to keep in mind if your patient's stable or not. Okay. If you have an unstable patient due to bleeding, whatever, that automatically dictates what your management is. And then your obstetrical history is extremely important in terms of this first focus visit. Why is that? But it also very much will determine your immediate management. If I have a patient who has had 3 sections and she's in labor, well, she's going to get a repeat cesarean delivery, because you don't offer trial of labor beyond 2 cesarean deliveries. So if I know that she's had 3 sections, if she's in early labor, which ordinarily wouldn't, fine, she's in early labor, that's fine. But in this patient, no, because it's not that it's a problem, but you're planning for a cesarean delivery there. That's why the obstetric history is very important. Also, what we'll discuss, certain type of previous uterine scars. If the mom has had a classical cesarean delivery, just 1, for example, she's no longer a candidate for a trial of labor after cesarean, TOLAC. So that's why this obstetrical history is part of your focused evaluation, and it's extremely important. Okay, so that's why. So when we present cases and examples, it's always going to follow that one-liner. So you want to get really comfortable with that. And more than that, that's your key information. So let's move on to talking about the labor mechanics. And what I mean by that is that this is not going to review all the foundational material, but just the highlights that you really need to understand for your clinical exposure and also for your examinations. Remember that labor basically involves 4 components. You have your, and they label it as the 4 Ps, which is actually a good way to remember it. I'm not really one for mnemonics, but this helps. So passage, which is the pelvic architecture, meaning that the bony pelvis, because that's what you have to deal with. That's not going to change. The tissue and everything else, you can accommodate space if you need to. Episiotomies usually are not required, but the point is that that will vary in patients, but the bones are going to be what they are. Then you have your passenger, which is anything having to do with the fetus itself. So the fetal size, which is fetal weight, but presentation, meaning, so there's a difference between presentation and position. Can anybody tell me what that is? Well, what's presentation? What does that refer to? Right. Yeah. Right. So the presentation is talking about if it's, that's well said, if it's breech or not. Breech meaning that a non-cephalic presentation. And we'll get into that. But position is, so say if you have a cephalic position, like head down, it's supposed to, what is the position going through, and we'll get through the cardinal movements, which I have here on the right side, but what is the position that is ideal for delivering it? Occiput or anterior, yeah. And more often than not, it's left occiput anterior, but it doesn't matter. So if you have occiput posterior, for example, where the baby is looking up towards the ceiling, if you're delivering, that prevents the fetus from going through these movements. So labor is obstructed. Not that it's impossible, but to put it plainly, mom has to push far longer because baby's not helping her because the head's extended. So it can't flex down through the canal. Okay, so that's the difference between presentation and position. You can have a cephalic presentation, which is ideal for delivery, but an abnormal or a less desirable position. Okay, and then movement applies to the cardinal movements of labor, which are the natural movements that baby undergoes while descending, which relates to the position and the presentation. So that's an absolute requirement, and it will dictate what your management is, especially position, because presentation is sort of going to tell you, well, you may have to do a cesarean delivery or not, but position is something you actually can manage otherwise. Powers, that's referring to the uterine action and cervical resistance, but this is really talking about mom's progress through labor. We went over the uterine contractions on the fetal heart rate monitor. And I mentioned that there can be, if you put a pressure catheter in, you can measure the actual force, the power of the uterus itself. What you have to remember with that is that, just to remind you, it's over a 10-minute period, and you want to have, the number you want to have over a 10-minute period is greater than 200, it's called Montevideo units. That's just the name that was given to the units from who created it. But what this means is that if I have a patient and she's not making progress in labor, I put a catheter in, and over 10 minutes, she has greater than 200 Montevideo units, she should make cervical change. If not, then that's likely an arrest of dilatation. There's a specific definition for arrested dilatation to remember, which, and I'll mention it again, but just to mention it now, it's you have to have 4 hours with ruptured membranes on oxytocin. And if you have an intrauterine pressure catheter in, which you will, because it's standard, but the definition is if you have it in, it 4 hours on oxytocin, okay? Because that's adequate contractions. The definition says 4 hours with adequate contractions. You know it's adequate because of what we just talked about. Inadequate contractions can be one of the following. It could be that you just don't have an IUPC in, so you just know the frequency for whatever reason, because this has to apply nationally, so they may not have it. Or you have 6 hours where you're trying to get greater than 200 months of a day units and you don't manage it, so it's inadequate, but then they give 6 hours. So that's a definition you should know, but that's going to come up on the slides. So that's what it's speaking about in terms of powers. Any questions with that? We're going to put everything together, so it'll make sense. And then they have patient and the provider, meaning that both have to work together, because if one has an idea that is not, if they're not on the same team, that will most certainly hold up the labor process on both sides. So it's really important to have a realistic expectation about what is going to happen. Sometimes you have that on extreme ends on both sides. You have a patient who has a birth plan, it's not possible, right? And then you have on the provider end, sometimes providers are just impatient, so they don't want to wait for, or they don't want to manage it per se. Not that they don't want to manage it, but they're less likely to, more likely to proceed with cesarean delivery. So in talking about our passage, there's 4 different types of pelvises that they like to sometimes ask you about. So which one of these is the ideal one? Probably guessed it because it says gynecoid, right? Yeah, but even just the picture, right? It's a nice circle. A gynecoid pelvis is an ideal for delivering a baby. Then you have these other sort of shapes. Your patelloploid is like a flattened, truncated pelvis. You're more likely to have an occiput transverse presentation with these pelvises. And they sometimes will like to ask you which sort of racial groups will have this pelvis, even though now I feel like people are so sensitive, they probably won't. But you'll see this in your Chinese population. But that being said, they deliver all the time. Like where I was at in my previous institution, there was a big Chinese population there, and they had no trouble. So, but that being said, they have a patelloploid pelvis, and that's associated with an occiput transverse position. Okay, because it's kind of flattened. Your anthropoid is you have a it has an increased AP diameter, and you are more likely to have an occiput posterior position because of that. OP. And then you can remember that because we're talking about AP diameter. Because what happens is that because the anterior posterior diameter is it's elongated, so you have an oval, but it's also truncated, so the head doesn't turn. So in the cardinal movements of labor, it just doesn't complete them, so you end up with an occiput posterior presentation. What that means is that instead of the baby, say if would be in the position, the flexing part where the head goes down, the baby's almost on its back, so it's looking up towards the ceiling, so it can't do that movement, which means that it's essentially mom's pushing against like a block. The baby's not helping at all, so that can prolong your labor. Not prevent it, but it'll prolong it. Sometimes You have situations where you have multiparous patients and the baby descends too quickly and they they are unable to complete those steps. So you'll have someone who's a para 3, para 4, and they're pushing and it's taking them a while. And you're like, well, you know, we've been here for like 2-3 hours. What's the problem? And it's because sometimes that position makes it longer. And then you have android pelvis, which is shaped kind of like a heart. And those are the ones. So you want to remember just gynecoid. Usually Hispanic or Jewish patients will have this one. Black race women will have android or anthropoid, but that's usually just for testing purposes. It's not like you're like, oh, well, you know, it's not going to work now. But except to be aware for this OP and OT association. Okay. Speaking of which, this is what I'm talking about when we talk about occiput posterior, anterior, blah, blah, blah. Try to get a sense of like what it actually looks like if the head is facing you. So if you're facing mom, what does that look like? Okay. Now your occiput anterior means, say, let's just skip to this because I think that's sometimes hard to understand. What it is so this is the bony pelvis, okay? But this part is, so this is the sacrum. You always want to orient yourself to like, where's the back? That's easy enough to do. And because the sacrum is in the back and the symphysis is anterior, okay? So this is flipped to what you're actually going to see if you're facing a patient. As in the pubic symphysis is here, it's anterior. And posterior is where the spine is, okay? So the occiput, which is behind, if the occiput is anterior, then you know that this is the posterior surface, but the way to think about it is that that is anterior to your view, okay? So if you're looking at this view on the right, say if you have the skull here, your occiput is here, okay? And this is your frontal bone. So if I'm looking at it directly, my view, kind of like on ultrasound, this is your anterior and this is your posterior. Make sense? So if you say occiput anterior, that means that the occiput is on your view anteriorly, because you would say, well, you know, this is the posterior surface. That's what you just said, right? That's why it's a little confusing. But that's why it's occiput anterior, because the occiput is supposed to be behind. Because the way you want to think about it also is that the occiput anterior allows the baby's head to go like this. Allows it to flex. You can appreciate if the back of baby's head was reversed, say, so near the pubic symphysis, how's that head going to flex? It can't, right? So that's how it works. You may need to kind of like go over that a little bit in your head to understand it, but that's sort of the easiest way I could explain it to you is that, remember, baby's head has to flex during the cardinal movements. That's not possible otherwise. So, but these are your landmarks. These are where these things come from. These are other views of how the fetus also looks, if that helps you understand it, as opposed to occiput posterior, which you see here. And if you could appreciate, if this pubic symphysis is here, baby's eyes are looking towards the ceiling. You see that? You know, sometimes people will joke and say baby sunny side up. That's what they're talking about, because it's just up. And that matters because it influences your labor time. That's in your books everywhere, but to understand that is a little bit tricky. So you can sit with it and try to get it straight in your head, because it's really just a visual thing. Now, we already kind of jumped the gun and spoke about presentation a little bit, but the presentation is the leading part, okay? So cephalic breech, meaning that this doesn't necessarily mean that it's the feet, right? A breech presentation can also be, say, if the face is presenting, sometimes that can happen instead of the skull. So breech is just anything that's not cephalic. And then odd things can happen like shoulders or the hand can prolapse. Now, a malpresentation is not the same as malposition, and we discussed what malposition is. Because sometimes you have a situation, say that where baby is compound. That word compound means that the hand is in front of the head. That's not a breech presentation. That's just a malposition. And the reason why it matters is just because now you have to push out the head and you have a little bit of extra of a hand there too. Sometimes it could slip out. Those are all just terms. So you have to get familiar with when we're talking about this, because you'll hear on the floors and everything that they'll kind of quickly say things like that. You want to be on the same page. And then malposition is anything that's not occiput anterior, either if it's direct or right occiput or left occiput. Occiput transverse is when it doesn't turn, but that's not usual, except for maybe if you have the pelvis that I mentioned. Okay. Any questions with that stuff? After this, we're going to kind of quickly move through fundamentals. But so I mentioned the cardinal movements of labor a lot. So now that you know all of the terms, this is going to make a whole lot more sense. So your onset of labor, that means that mom has just started contracting. So baby hasn't descended or anything. Labor has started. So now you have your descent, meaning that baby is now, your station, say, when your onset of labor is going to be like -3. By the way, what's our landmark for your stations? No, like the landmarks though. Like, what is your reference? What's 0? At what level? That's important because at 0, it's -5. -5 is classic, but it's usually -3 is what we say, -3 + 3. It's these guys, the ischial spines. Okay, that's important to know because that's where your reference is. We have our simulator up, so I'll have you kind of do exams on it. And that it's pretty realistic for what it is. But if you can appreciate also from these pictures, you see how you can tell that the head is coming closer to you because the area of the pink borders, meaning that's the canal, is getting less. So on the onset of labor, head is high, -3, okay? Then descent and flexion is your second step. So the head starts to come down and it flexes once. I mean, it begins to flex. So then you have internal rotation because the head flexes down, but if you can see, it's still in a transverse position, right? And then it begins to rotate from a transverse position to an occiput anterior position, okay? And then it continues to rotate until it's direct. And then that's where extension happens. It externally rotates. And then you have, this is like your last step here is your flexion, okay? And that results in your spontaneous delivery. So if you don't perform this last step, that is, and you have what's called a persistent occiput posterior position, then you may have an obstructed labor. And I mentioned this because that's why it says a persistent occiput posterior, because it's supposed to resolve and it just doesn't. So I like to ask you those movements. So make sure that you're familiar with them. This part here, the extension looks like the head is out, it's not. Just know that. That part is not, it doesn't come out extended. It has to extend and then do external rotation and then flex and deliver. Okay. So onset of labor, descent and flexion, internal rotation, extension, external rotation, flexion, delivery. I told you you can have face presentations and then there's breech presentations. Okay. The bottom line for the face presentations is that mentum posterior cannot deliver vaginally. It just will never come out. It's stuck. So you need, that's an indication for cesarean delivery. Okay. You want to get those straight in your head because there's not many of them. Indication for cesarean delivery in an unstable patient, both mom or baby or both. This position here, and this is not like in the Northeast, we will not do a breech vaginal delivery. Like this is an indication for cesarean delivery. Mentum anterior is different. Mentum is referring to the chin. So if that's in an anterior position, meaning that it's on the top part, if you're looking, they could deliver it. It'll just take them a little longer. Breech presentations where the feet are the presenting part, they have different designations, but they're not practically applied because it's just breech. Your management is the same regardless of it's anterior, posterior, whatever, but it's sacrum then. But that's not a common thing. You'll see it in the book, but don't even worry about it. In terms of, it doesn't change your management there. Breech presentations, if you have the legs flexed straight up, that's frank breech. Complete is when they're both bent at the knee. And footling is when one is prolapsed and the other is bent. Either way, around these parts, you're going to do a cesarean delivery. So when there are some exceptions to that, but for now, we'll speak of it that way. Any questions with that? Now we're going to actually get into how you manage these things.
The internal and external rotation
Uh-huh.
is just reference to the length, not the direction that they're turning.
Now the baby's head is turning. That's what it's referring to.
But like turning internally and then externally. That doesn't matter.
The take home from that is that the most they'll ask you about it is just like they'll list the steps. And it's like, what are they? From a practical standpoint, you have to just know that if any of those don't happen for whatever reason, you can have a malposition and an obstructed labor. And the reason why that wouldn't happen is because sometimes descent is too quick. They have like rapid descent. And then it's just too fast. That can also be a reason why you might get a shoulder dystocia too on a baby that's not very big, because it just kind of goes, it doesn't actually move, so it gets stuck. That's the practical consideration there. And also why you'll hear terms like persistent OP. Okay, so let's talk about, now this part is going to be talking about like the medicines and options you have to induce labor, meaning to start it, augment labor, meaning labor has started and you want it to go faster, or it had stopped and then it stalled. And what those terms are and what you should do with them. This is kind of like your toolbox now. So first of all, you have to know what the definition of labor actually is. So remind yourself that it's regular uterine contractions, but importantly, that cause cervical softening and dilation. If someone's contracting and they're not making cervical change, they're not in labor. You'll hear them say that. It's like, oh, she's contracting, but she's not in labor. So then you got to figure out why she's contracting, and which is, it can be due for a number of different reasons, but what's a really common one? No. Usually you have to induce them if they have a fetal demise. They don't usually go into labor, and that's a problem because they don't get the signals. Dehydration, because the uterus starts to cramp, and you'll see like some contraction activity there. And that's because It's just because it's reacting like a muscle, right? And also it's trying to recruit ADH, which is structurally similar to oxytocin, so it contracts. But that's not labor contractions. That's not going to make you dilate, right? So you have to define if you're in labor. So there's something called a Bishop score, which you've probably seen, that is a number that will tell you if it's originally it was used to see if labor is going to happen spontaneously or not. But that's usually what you'll hear is that if the mom has a favorable cervix or not. They like to ask you about that score. And usually it's pretty intuitive, but we'll go over what that is. And that's basically going to determine if you have a patient you want to induce for labor, are you going to need to use certain medicines or not, or which are really the cervical ripening agents, which we'll discuss. And then obviously your considerations, as we mentioned, for your sort of focused evaluation are important too. Remember your gestational age. If you're dealing with a threshold of viability fetus at 20, 30 weeks, it's a different story than someone who is 39 weeks. We mentioned prior cesarean deliveries, fetal status, acuity, and also comorbid conditions, because some of these medicines you can't use in certain conditions. This is your Bishop score here. A lot of this is academic, but the point is that when we speak about cervical ripening, that means that's the phase of labor where the cervix itself begins to soften and thin, and then eventually will dilate, but with the help of uterine contractions. But when you're having a patient that presents for induction of labor, you do an exam and you calculate a Bishop score. If the Bishop score is really low, this says lower than 5 is unfavorable. Usually you'll see, especially in EMRs, that they use 8, less than 8, greater than 8. Because a lot of these follow suit. But the point is that if you're trying to induce a patient, there's a class of medicines that can be used only for cervical ripening to get the cervix softened. And that has to happen before you use other medicines, which are more targeted towards enhancing uterine contractions. That's how you have to start to think about it. Just normal physiology, the cervix remodels. And if that part doesn't happen, your labor is not going to progress. So if you have a patient who has a very low Bishop score and you just kind of jump to oxytocin IV, which is used to facilitate contractions, if you haven't done cervical ripening, it's not going to work as well. And it won't work at all sometimes. So the way that the score works, and just be familiar with it, really for test purposes. I feel like this is also on my boards, which is kind of funny. But the important thing to know in order to understand this is that say this is a sagittal view of the vaginal canal, okay? This is the opening of the vagina here. And then what you have is the cervix. So this is a cervical uterine junction, and this here is the uterus, this SJ. That's our baby. The cervix starts out kind of tucked in the back, almost facing, it's facing posteriorly. So if you want to think of it one way, it's kind of facing the spine almost. So that's why your position starts with posterior. That's a non-laboring cervix, as I say. It's not remodeled at all. So it's tucked in the back. As such, the consistency is firm. It's not softened at all. It's usually 0 to 30% efface, but most people don't say 30%. They'll say if it's 0%, I'd say if it's, no one says 0%. They'll say, if you've ever heard closed long posterior, like a long cervix, because effacement, what's effacement? Right. It's the thickness of the cervix. That's how you want to think about it. So if you're 0% effaced, that means that cervix is long. It has a thickness to it, like a length, because that's the thickness. this, if you're gonna think about the cervix here, this part is your effacement or lack thereof, okay? So if someone is, they'll say closed long posterior, that follows suit because it hasn't remodeled. Closed, and then your station is -3. So it all makes sense. You're not gonna have a patient who's 0% effaced and 5 centimeters dilated. That makes no sense. So as the uterine contractions occur and cervical short ripening happens, this cervix will then begin to face anteriorly, meaning that it's now looking right at you. Okay, so that's what an anterior position is, and that's why it's further along on the scale. And then if it's in between as it's moving, you could have mid position where it's kind of facing the floor. Okay, because it twists from posteriorly and then goes out anteriorly. That's normal physiology. So what you would expect is that as you go from a 0 numbering of posterior firm, closed, etc., you go all the way to anterior soft, 60 to 70%, 3 to 4, etc. Okay, that's how that works, and that's what's happening to the cervix. So you know, they'll ask you, well, you know, if you have middle position and medium consistency is 70%, and she's 2 centimeters and -1, what's her score? That's what you have to know for your test. Okay. Practically speaking, you do an exam, and the numbers will all kind of make sense. And that'll tell you if you need cervical ripening or not, if it's less than 8 or greater than 8. Got it? It's more important you know how to interpret it than to actually know all of the numbers, but it makes sense. And even if you don't really remember it, you can guess because of the way that it works. So if we have a patient who we want to induce for labor, we'll get into the specific medicines we want to use for cervical ripening, but it's important to discuss why you would even want to induce a patient for labor in the first place. The bottom line is that you have determined as an obstetrician that the risk of worsening maternal or fetal status is higher than waiting for spontaneous labor to occur. So we're like, if we let it go and we wait, we're going to run into a problem. A really good example of this is hypertensive disorders in pregnancy. We'll have a whole lecture about that. But the thing to remember is if you have gestational hypertension, which is just isolated a new development of hypertension in pregnancy, which means beyond 20 weeks, you say, well, what's the big deal? It's okay, it's just hypertension and it's not that bad. Well, hypertension is on a spectrum. You want to think of it that way. So gestational hypertension, if you leave it, more often than not, will lead to preeclampsia with severe features. So you want to induce them early. You induce them at 37 weeks. Okay. And that's the earliest you can do it for that condition. So that's an example of we're saying that worsening status is probable over just waiting. Otherwise, if we're waiting for a mom to go into labor, we can take it all the way to what is defined as late term. Does anybody know how many weeks that is? Well, a term pregnancy is how many weeks? 40, okay? So your late term is 41. So if you're 41 weeks, you're now in a late term pregnancy. And we're going to get into different reasons why it's not desirable to let a fetus go beyond, but there's an increase in complications. So if you're 41 weeks and you haven't went into spontaneous labor, we're saying that the fetal risk and also maternal risk is higher. So we want to get that started. And most certainly, if you're beyond 42 or beyond, that's called post-term. You don't really see much of that. I think I maybe saw it like twice in my residency, where they really wanted, the mom really wanted to go in spontaneous labor, and she ended up coming at 42 and 3. And she ended up having a cesarean delivery only because the fetus, there was just category 2 tracing most of the time. Every time there was a contraction, baby had a decel, and we couldn't resolve it. So, bunch of reasons. So how do we do it? Finally, right? So if you need to, if your Bishop score is low and you need a cervical ripening agent, which is usually that a patient has uneffaced cervix. So effacement is like 0, 30, and closed. The medicines you can use are this. I say the dual agent is preferred. What we're talking about in terms of dual agent is the use of a cervical ripening catheter plus a pharmacologic agent. Okay. So you'll hear them say on the floor, we'll do a Cook and Cytotec, right? So what that means is that the cervical Foley, or the cervical ripening balloon, it's the brand we have is Cook, and that's actually pretty common, Cook Medical. So it's a Cook balloon, and then you will usually use that with prostaglandins, either misoprostol or dinoprostone, and misoprostol trade name is Cytotec. So that's what it is. You'll hear that all the time because the overall induction time is shorter if you use the catheter plus, right? Plus something else. Remember, your prostaglandins are contraindicated in cesarean delivery, previous cesarean deliveries. You cannot use them, okay? Because that increases the rate of uterine rupture. So they're contraindicated. So right off the bat, that's why your obstetric history is extremely important. You got to know if they've had a previous cesarean delivery or not. What you'll find in OBGYN is that like the medicines that you use they're ubiquitously used for all different types of purposes. Like misoprostol is used for, you'll see it's used for everything, or oxytocin is used for everything. Do you know why that is? It's a very simple answer, because what you're trying to achieve in all pathologic states of obstetrics and gynecology really is trying to get the uterus to contract and push something out. Either it's not contracting because you delivered a baby and now you're hemorrhaging, which is called uterine atony, postpartum hemorrhage. Or if you're a non-pregnant patient, say you had a miscarriage and you have products of conception there, you want those to pass, stuff like that. So it's just because it has the same function. The uterus has a function to accommodate a pregnancy or expel things that shouldn't be there. So that's why all medicines are more or less targeted towards achieving that end. So if you think of it that way, the pharmacology is very easy. So I told you that labor is a process of cervical softening, shortening by means of uterine contraction. So we have to get that to happen. So that's why with this, the ripening balloon, use the prostaglandins, or you can use oxytocin with the balloon for cervical ripening purposes, but you leave it on a lower dose than you would for augmentation. You don't got to know doses. That's just a concept. This is what the cervical Foley balloon looks like. So it's passed in between the cervix, and it doesn't pry it open. What it does is it kind of sandwiches it, and they figured that would kick off the signals that it's like, oh, I guess something's happening because there's contact here. Turns out they were right. It stimulates natural release of prostaglandins and chemokines, and they showed that in like biochemical studies. And it works. We know, we use it all the time. It's rarely used in isolation unless only in situations where, say, you have a category 2 tracing. That's an indication to induce a mom, because you're like, well, something's going on and we can't resolve it, so we should, get you delivered. But you can reverse your catheter because you could just take it out. If you put the misoprostol in there, the pill, that's it. Can't really do anything. Dinoprostone has an insert which you can remove, but I'll show you that. So the bottom line here is that pretty much the cervical Foley balloon, the evidence is kind of displayed as in terms of cost. It has a lower cost than using pharmacological agents, and it has a reduced risk of uterine tachysystole without fetal heart rate changes, as you might imagine, because there's no pharmacology here. It's just it's really just engaging the maternal physiology. Now, prostaglandins you can add with it. Misoprostol I already mentioned. That's prostaglandin E1. Dinoprostone is prostaglandin E2. All right. Dinoprostone, which we don't have on formulary here, but it actually is in a tab insert. So this is nice if you have a fetus who has, say, a lot of times you have growth restricted fetuses that are very delicate. Every time there's a contraction, there's something, whatever. So if you're concerned that maybe this intervention may cause undue stress to the fetus and you want to reverse it, well, this is good because you could put the insert transverse under the cervix and leave it there. If there's a problem, you pull it. But it's the same medicine. Both prostaglandins. And then here I just have a little summary for you. I mentioned how misoprostol is used a lot. So for cervical ripening, you have like a 25 microgram is your dosing for cervical ripening. For medical management and missed abortion, it's higher, 800 micrograms. And then postpartum hemorrhage is 1,000. So I mean, like it just increases it, but it's the same concept. And they increase the likelihood of vaginal delivery, but you have an increased risk of tachysystole. But if you use it judiciously, you'll be fine. And we use it a lot, all the time. Oxytocin, everybody knows what this drug is, even if you're not a doctor. It's the most commonly used drugs, or one of the most commonly used drugs in the United States. Every sort of labor syndicate across the country is going to use oxytocin in one way or another. And it's an IV infusion. It's quick on, quick off. The pharmacokinetics are about 3 to 5 minutes to start with a steady state at like 40 minutes. So if you turn it on in 5 minutes, you're going to expect to see something. This is the bottom line. It's quick on, quick off. So sometimes the fetus is stressed out. You rush into the room. You have a prolonged decel, like we mentioned. First thing, PICC goes off. You do your resuscitative maneuvers. That's usually enough. Because if it's quick onset. You'll hear other things. Has anybody heard of this? Membrane stripping? You may hear people say, it's like, oh, well, I stripped her membrane, so hopefully she comes back in labor. This is like a sort of barbaric thing where you pretty much, if you have a patient who is not yet in labor in the clinic, this is something that's an outpatient thing, meaning that if someone's admitted for induction, this is not what you start with. But if you see a patient in clinic and she's 40 weeks, say, and you want to get things started, but you don't want to admit her for that, you can wait until 41 weeks until she's late term. You may do this procedure, and that actually, it shows in pretty consistent studies that this procedure increases the likelihood of spontaneous labor within 48 hours and reduces the need for other pharmacologic agents. What it is, and then they did a biochemical study too, because it increases this prostaglandin F2 alpha. It's just one of the prostaglandins in the cascade, even though labor physiology is not well understood. But what this is literally the operator putting his or her finger in the canal and sweeping it around to get the amnion and the chorion to kind of separate off the wall. Okay. You know it works because I've had colleagues of mine who are OBGYNs and this is really painful, okay? And they would be like, yeah, I told my doctor to start stripping my membranes 38 weeks. So it's just kind of like an anecdotal thing. I'm like, well, if you're going through that and you know what it's about, then it must work. And it does. But the thing is, you have to have somewhat of an open cervix to do it, right? Because if you're closed long posterior, like you can't get there because it's inside. But be familiar with that, you'll hear. Amniotomy is something that's used for augmentation of labor, meaning that this is where you hear someone says broke or water, AROM, right? This is your artificial rupture of membranes. And it's not recommended to use it alone, as in you're not going to induce a patient with this. What I will say is that multiparous patients respond more readily to amniotomy. So say, for example, you have a patient, you do cervical ripening, and say she's para 3 babies before vaginal delivery. And she comes in for induction, say she's 41 weeks. What can you do to start? She's closed long and posterior. Yeah, but what? Hmm? Yeah, I said, yeah, but what? Hmm? You would give her pit after our previous discussion? Principle is that you got to evaluate what's in your toolbox. So for cervical ripening, you can use oxytocin, you can use a cervical ripening balloon, and you could use prostaglandins. For augmentation of labor, you pretty much only have oxytocin, and you could break a patient's water, perform an amniotomy. So it's behooves you, unless you have a contraindication, to not really start with PIT because you're going to need that later potentially, right? So a strategy is, and this is how decisions are made for these things, is that, well, if I need to induce a patient, if I can use prostaglandins, I'm going to do that first. And then once that cervical ripening phase is completed and the balloon is removed, then I can put the patient on oxytocin to increase the contractions. If she's already on it, I don't have anything else, right? But so after you do your cervical ripening, and multiparous patients, if they're dilated even to 3 or usually, I should say, when your cervical ripening is completed and you use a cervical ripening balloon, that means you're about 4 to 5 centimeters dilated because that's how big the balloon is, more or less. So if you're 4 to 5 centimeters dilated and you're usually about 50 or 60% effaced, then if you perform an amniotomy on a multiparous patient, that's usually all you need. On a nulliparous patient, meaning a first baby, it's not as efficacious, and it's recommended you perform that step when the patient is in active labor, which is how many centimeters? Active labor? 6. So, and most institutions across the country have this sort of yellow, it's called Amni hook, and it's a ridged piece of plastic is what it is. And you make contact with the amniotic sac here and just kind of nick it with the, what you're supposed to do is make a small hole and have the head descend a little bit once the fluid comes, so an umbilical cord or something doesn't come out at you, and then you spread it apart. You're not going to see that, of course, because you'll just see a hand doing an exam. But if you do that, if you go into OBGYN and things, that's what it is. So then you put it all together. That's it. Like there's no other options. Okay. So remind yourself about the first stage, second stage, third stage. So your first stage of labor is your dilation phase, which means you're going 0 to 10, with 6 being active labor. Okay. This is your time. So you're in your first stage of labor. This is where you're going to be using your induction and augmentation agents. If you have a problem on this stage, it's referred to a arrest of dilatation. Okay. Now, second stage is when, putting it plainly, mom's ready to push, completely dilated, but then, especially first baby, she's still 0 station, completely dilated 10 centimeters. She has some pushing to do. That's why it's called labor. But this is the stage where you can use operative delivery devices like vacuum or forceps assisted deliveries if you need. Your third stage is when placenta delivers, and this is where postpartum hemorrhages occur. So kind of get that sorted in your mind as well. This is a very old birth, a labor curve, but the point is that nulliparous patients are expected to have a longer labor duration than premiparous patients. Multiparous patients. And that's different by race, by, social determinants of health, all these other things. So you don't got to worry about the exact times, but just know that that's a trend. That's expected. We mentioned an IUPC a little bit, but this is what they look like. It kind of passes over the baby like this. You just kind of feed it through. You could also remember, we mentioned this before, but you could also use, this is how you administer amnio infusions as well. Greater than 200 Montevideo units is important, but we kind of beat this to death, but this is just a slide to remind yourself of that. In terms of recommendations for the first stage, meaning that the dilation phase, really, they keep trying to expand it because they want to reduce the primary cesarean delivery rate. There's really no recommendations, essentially. You can give them as much time as mom and baby are stable. However, when you're in active labor in the first stage, so your latent phase is before 6 centimeters. That's what I was just referring to. If you're in active labor, which is 6 centimeters, now the definition I had mentioned to you earlier should make a bit more sense, where you have an arrest of dilatation, which is an arrest of the active phase in the first stage of labor, is reserved for women who are at or beyond 6 centimeters with ruptured membranes who fail to progress despite 4 hours of adequate uterine activity as measured by Montevideo units, or 6 hours with oxytocin of inadequate uterine activity, okay? And we already went over what that is. So just know that definition because it's pretty important in managing things. Second stage, meaning that when she's fully dilated, there's not really recommendations in terms of the actual overall time. What I usually say is if they've been pushing for 4 hours, it's not going to happen. Because we've been in situations where it took mom 4 hours to push. This, where it says before diagnosing arrest, it says allowing for 2 hours for multips and 3 hours for nulliparous patients. That's kind of assuming that your position is correct. If you're dealing with an occiput posterior position, for example, it's going to take you longer. And it's possible, but it's going to take you longer. But if it's been 4 hours with good effort, it's not going to happen. Very unlikely. Now, this comes from the obstetric care consensus from ACOG. It says longer durations may be appropriate, and it says with use of epidural analgesia. But it also then says in the anesthesia practice bulletin, the OB anesthesia practice bulletin, that your epidural will reduce your first stage labor time by 90 minutes, which is actually true. So the epidural sometimes doesn't encourage a active pushing effort. But if I give mom an epidural when she's like 3 centimeters, that will shorten her time. Okay. They're not going to ask you questions like that because that's a hard question to ask, but just so you know. Like I said, operative vaginal deliveries can happen in the second stage, and that the requirement for that is you need a cephalic presentation and they have to be in at least +2 station. Okay. If you're 0 stations, too high. You got to come down a little bit. Manual rotation of the fetal occiput is something you can try. Like if the head is occiput posterior, you can try to turn it. Sometimes it doesn't work, but you could try it. I've done that a couple of times and it's worked. But the problem with that is that usually mom's labor is protracted and the fetal head has swelling, which is called caput. It kind of makes those bony landmarks hard to feel. So you don't really know the position of the head. You can't be twisting the head if you don't know what the position is. So that's just a practical limitation. And it's just what it sounds like. You put the operator's hand and you tell mom to push, and it encourages your occiput posterior position, which is here. Another way to view that. To bring it anterior. Operative vaginal deliveries, forceps that go over the baby's face, and it's like a forceps delivery is not like you kind of wiggle it. It's like an up and down motion like this, kind of like almost like you're trying to like wrench something out, as opposed to the vacuum where it's just you try to simulate the cardinal movements of labor. So if you've seen you may, because they're not that uncommon, but in the sim, I'm going to show you how to do that as well, but with the vacuum anyway. You try with the vacuum assisted delivery, you try to simulate the cardinal movements of labor. So you pull down as mom's pushing, and then you, as baby is about to come out, you lift up. Because it's a flexion down and then extending out. And that's pretty much it. Do you have any questions? No questions? Okay. Well, we are out of time, but what I will do next time is pretty much the whole time will just be scenarios. So make sure you're getting it. Okay. And then we're going to have a sim where we actually do that with the mannequin. But there's not a whole lot to do in those situations. What we're going to do with the sim is once we go over, say, like postpartum hemorrhage and hypertensive disorders, I'm going to be like, all right, start from the beginning to the end and hit all the points. And do you remember? So, because all of it builds, because ultimately all of these things are how you manage a pregnant patient. The non-pregnant patient is going to be a couple of lectures, and it's just kind of, that's mainly pharmacology and surgery is what that has to do with. But this is really it. And actually, maybe the first pass is a lot, but if you go over it, it's not that much. The labor principles don't hang too heavy on them. Just know what's going on. Know the medicines really, and your recommendations in terms of your stages. And that's pretty much it. I mean, you don't got to memorize all of those that have the stage recommendations. Know the definition of arrest in the active phase. That's pretty much it. And then be familiar with everything else. So then when you're on your on labor and delivery, you'll know what they're doing. And then the questions we'll ask you on the test, they'll be like, oh, well, they basically want to see when you would need a C-section or not, if they have arrested labor or not. You know, if someone says they come in labor and they have a couple of sections, what do you do, sort of thing. It'll make sense, especially when we do the examples.